The information shared on CNS Unfiltered is for educational purposes only and is not intended to diagnose, treat, cure, or prevent any disease. Always consult your healthcare provider before making any health or lifestyle changes. The views shared are those of guests and do not necessarily reflect those of Innate Clinical Nutrition or its affiliates. This episode includes affiliate links, which help support the show.
Hello and welcome. I am Jenna Salisbury, and this is CNS Unfiltered, a show where clinical nutrition specialists uncover what traditional medicine overlooks. Whether you're a practicing CNS or you're studying to become one, then you know how big of a role that research plays in your career. Reading and analyzing research and incorporating research-backed methods and concepts into your practice is the name of our game. It is how we develop the scope of our understanding of the body and its biochemistry, and it helps us to deepen our own practices so as to better serve the clients who need us. The necessity for practitioners to be well-read is what makes resources like Journal Club so important for emerging CNSs. Maybe Journal Club is actually relevant for you now as you continue your studies in preparation for those CNS credentials, or even moving into your doctorate or PhD where publishing for yourself is forefront in your mind. The act of meeting with peers and asking questions, discussing implications, and analyzing the outcomes of emerging research is an invaluable way to keep growing in this field. This is why I'm bringing Journal Club to CNS Unfiltered. Once a quarter, we'll discuss some of the emerging research in the field of clinical nutrition here on the podcast. But we're taking it a step further. We're going to do this with the authors of the paper themselves. Each episode, I'll review a paper with the author and ask them questions about the research that guided that paper. The author will share their process, talk about their personal practice and experience, possibly touch on a case study that may have impacted their research, and explain what they thought the biggest takeaways were. If you're a practicing CNS, this series is a way to regularly get access to some of the emerging clinical research presented by fellow CNSs that's shaping our field. If you're still working on those credentials, this series can supplement, not replace, the Journal Club you may already be engaging with. Since these episodes will be discussing research papers, it's highly recommended that you read the paper beforehand or take a peek after. Each one will be linked in the episode's show notes, and I'll post them in our bio on Instagram the Friday before the episode drops. I hope you're ready to nerd out with me. I'm so excited to have you here for our very first Journal Club episode. Stay tuned. Hello, everybody, and welcome to CNS Unfiltered. Today, we are going to shake it up a bit. So instead of following some of our normal format, this will be our first CNS Unfiltered Journal Club. And I can't express how excited I am to be able to dig in deep into some of this research with CNSs who have pioneered the literature and have written it to bring it all to us to amplify our practice and to give us some more insights behind the scenes. Today, we have Corey Schuler. And Corey Schuler came with a paper, Energy Allocation, Resilience, and Endocrine Integration. He has written this paper with the accompanying authors, Allison Sari, Laura Zakara, Sean Tazone, Alexander Reinhardt, and Richard Harris. So, Corey, thank you so much for joining us today, for all of your work you've put into our field and our industry, and for sharing it here today on CNS Unfiltered. So, Corey has shared a little bit about his background before I turn it over to him to kind of share a little bit more. Wonderful background. Started as a chiropractor, went to school during that to get his CNS, practiced both of those before then going back to be a nurse practitioner and finishing his PhD in health science, focusing in depression and exercise. Thank you, Corey. Welcome.
Thanks for having me, John. I appreciate it.
My pleasure. So I'm going to turn it over to you for a second so you can explain a little bit more about yourself. How'd you get into the research side of things, and um, kind of bridge us into a little bit of your paper, and then we'll jump in.
Absolutely. Well, like most CNSs, I loved reading the literature. I always said that my most visited page on my browser was always PubMed, and I did that all through school, like a lot of us, and just kind of fell in love with not just tearing apart literature, because that's sort of easy, right? It's kind of easy to say, oh, this isn't good, or they should have done it this way, but what can we glean from it? What are the answers that we're getting closer to with research, and trying to apply it to cases, because that's ultimately trying to help people is the goal for reading the research. It's not just an academic exercise. So I've always done that. And when I was in my master's program, I found that there were huge gaps. And of course, that gap is almost always done by original research. Let's do a randomized controlled trial. Let's look at how this one intervention with this population does this thing. And then I started sort of doing the math in my head, and it's like, well, there's a bunch of different ingredients, supplements, there's a bunch of different foods, there's a bunch of different patient presentations, and it becomes, exponential as far as like, I just came to terms with the fact of I'm not going to know all the answers because we're not going to do all of this research by the time I retire or die. Like this,
Fair.
there's too much. So we're going to have to sort this out. And I learned a word that I have used a lot, especially recently, and that was heuristic. And a heuristic is essentially a shortcut, but a theory-based shortcut. Like, how do you pragmatize groups without extrapolating evidence, and how does it make some sense? And so I started building these heuristics really for myself, because as a nutritionist, I wasn't seeing 10 of the same people every day. So occasionally you'd see somebody that you just hadn't seen in a while, or see a presentation you hadn't seen in a while. And so I needed to get quick about getting up to speed on not only what was out there in the literature, but how to apply it to somebody in practice. So I guess that's the long answer
Love it.
of how I got there. But as you noted, I've been doing this for a minute. I became a CNS in 2010, and just been working in both industry and private practice really ever since.
That is wonderful. And yeah, you've mentioned the word heuristic. What is it again?
Heuristic.
Heuristic.
Yeah.
I Googled it.
Yeah.
But that was wonderful. And it really kind of, if I remember correctly, because now through all of my notes, I would have to find, oh, here it is. Yeah, the note I put with it was all medicine and all poison is in the dosing, from like how I kind of extrapolated the definition and what is trying to do, right? Like we have a balance that we're always trying to get at. And then at what dosing, at what position, at what format the body is accepting, does this actually work? And you actually break down some of your thoughts in that framework. So thanks for breaking that down. And we're going to jump into a little bit more of that as we go.
Yeah, absolutely.
So Energy Allocation, Resilience, and Endocrine Integration. This paper is amazing. I say that wholeheartedly, and I really believe like this should really be a paper that is fundamental to anyone in the healthcare. I don't care if it's a physician, a nurse practitioner, or a CNS, because I can speak for me, right? And you don't know, maybe the rest of the audience knows because I've said it a few times, but I actually graduated with my RD in 2010 and then switched over to a CNS. But through those years of just really working with patients and going through the webinars and the teachings and stuff, like I had to extrapolate, like, okay, we have operating systems. That's foundation. Okay, we have substrates. Foundation number 2. Okay, operating systems, where they at? Okay. And right, you build a level of a sequence or a system because that's the only way you're going to be able to know quickly where that person's at, right, as a practitioner. But this was so gratifying to read because everything I put together myself, just from clinical thinking and practice, you laid out flawlessly, beautifully, like very, very well done. And this, I feel, is the foundation that if people can really take this system, practitioners, right, can really take this system and understand it and look at that as a system, you now know in the big, beautiful organism machine that we're operating, where to throw the wrench, right? You get to decide. You have a lot more precise allocation of what you're doing, what modalities you need to subscribe to, and put pressure on to really move the needle and move the systems. And I am so excited to share this with everybody. I just kind of gave some overview and some of my thoughts on it, but please take over and tell me what got you here and what this meant to you.
Very, very kind words, Jenna. I really appreciate it. And it was a labor of love, and I've never given birth, but it sort of felt like a
I'll
similar
give it to
process.
you.
So as we're we gestated a bit, and actually I have a little bit of a story
Ooh.
because like people ask the question like, how does it come to be? And it started off as just a discussion with my scientific advisory board, which are the authors of the paper, and we were talking, and it's like, well, people get really frustrated when they have all the thyroid symptoms, right? They have cognitive slowing, they have weight gain, they're like constipation, hair changes, skin changes. And so they go to their doctor or their healthcare practitioner and they say, I think I have a thyroid problem, check my thyroid. And then, 2 or 3 days later, or maybe a week later, they're told that it's not your thyroid, everything's normal, go on with your life, but they still have those problems. And so that's how the conversation started. And we just started thinking aloud, like, well, what could it be? I mean, clearly there's probably another system, but then we came to this idea. Most models of medicine, healthcare are look at organs individually. And this how it came to be, this energy allocation system really looks at how the body distributes energy across systems. When you say energy, a lot of us think mitochondria, and but really every adaptive process, whether that's an immune activity, whether it's cognition, hormone signaling, it all requires ATP, what the mitochondria is generating. But the mitochondria is within the cell. The mitochondria doesn't share its ATP. It makes ATP for its own cellular machinery, and that's kind of it. So that's to say, oh, it's mitochondria energy. That's insufficient of an explanation. But when we put it together, it's like, well, what coordinates that? There's got to be a coordinating system because there's always a coordinating system. And then we realize it's not just one system. It's not just the hypothalamic pituitary thyroid axis that's doing this, the hypothalamic pituitary adrenal axis and the hypothalamic pituitary gonadal axis. So sex hormones, stress hormones, thyroid hormones, they're all interweaving in this. And now what we know clinically, and we always knew it, is that when energy is abundant, those systems all function together. pretty perfectly, beautifully, symphonically, if you will. But when energy becomes constrained, and that's where those pesky symptoms come in, the body starts prioritizing. And so, right, we know that stress pathways, they mobilize fuels. The thyroid signaling adjusts metabolic pace, and then reproductive and repair processes tend to be deferred. So that allows a new vernacular, a new vocabulary for us to hear about. Somebody thinks they have or might have hormone imbalance things. Okay, well, we don't have to just pick on the hormone system. We can draw from these other endocrine axes to help balance and regulate a energy misallocation. So yeah, we've created some shortcuts and ways of talking about that that make it a little bit easier.
Beautiful. And I just want to anchor this into clinical work because this, at least in how there are so many paths, right, for a CNS. And my path over the last over 13 years has been very patient driven practices. And so usually they're seeing the patient, the provider is seeing the patient, right? They get the functional labs, they do all that beautiful stuff. And then they come, excuse me, to see me. Every office that I've worked in has been bioidentical hormones and thyroid. And so, yes, I had to understand them. But in the beginning, I didn't manage those, right? The physician managed those. But after you're in this field for a little bit and you start building your thing, what I really noticed too is, everyone, if they're not in the functional ranges at this particular last practice I was at, was getting a medication, was getting armor thyroid or getting something. And then same with the bioidenticals where they get to me. I'm like, wait a second. We just had to shift some things up in the cycle here, or you're so high stressed right now. Of course, X, Y, and Z isn't up to par. Um, Maybe I'm going to give all my secrets away, but I'm going to give all my secrets away right now for how I would address that client because and I'm not trying to oversimplify your thing either, but it kind of simplifies it. So we have an operating system. Stress is always going to win. That's going to tell your body how we're operating, right? So if the body's like, hey, my number one job is to keep you alive. That's number one. That's priority. So if we got a little bit of nutrients coming in, or I can only process and absorb a little bit because we're in a stress state, those little bit of nutrients have to go towards keeping you alive. So they're going to go and they're going to fuel this, usually the adrenal piece of it, right? And we're going to downshift our thyroid and our sex hormones, which is why testosterone usually follows thyroid, is how I thought it, explained it. Right? The body's like, I got a little bit of resources and they have to go towards keeping you alive. So, of course, you're not going to feel like it's going to shut down the thyroid. It's not time to go dancing. It's going to be shutting down testosterone or sex hormones. It's not time to make babies, right? We have to allocate the resources. This is not infinite, right? If you don't eat, we start to get tired, right? Our energy goes away. And so the catch was, because when you give a medication, as you know, being a PA, especially during that first time, they usually feel better. But what happens the second or third pellet they get, or when their thyroid keeps changing, a reverse T3 keeps coming up, but they're like, I just spent $3,000 on all your thyroid and hormones and pellets, and I don't feel any better. We're missing the mark. And this is where we get to shine, because now you have the systems here someone can actually read and actually look through and say, okay, this is how we present that.
Yeah, absolutely. I've sort of been, how do I say, biased towards starting to look at patients really through these lenses now, because I've been talking about energy allocation for years, but it hasn't really come into a more formal framework. So now every patient I see becomes an energy allocation case. So I have lots to share about those.
Well, I'm ready whenever you are. Let's hear them. Because I can keep talking. I love this, but you are the expert, and I want to hear you and what really stood out in your investigation and your research and how to bring that clinically.
Yeah, when I talk to prescribing practitioners, whether it's other nurse practitioners like me or PAs or MDs, it's like, oh, well, I'll figure out the thyroid thing with thyroid hormone, and you bring up a good point. When you see a thyroid panel that looks a little bit sluggish, or maybe even frankly hypothyroid, the reflex, and this is the guidelines, right, where we want to provide thyroid hormones, and there's room for that. And not only room for it, that's what we should do when there's frank deficiency. But when there's not frank deficiency, sometimes adding in exogenous hormones or hormones from outside the body without understanding what else is going to do adds another layer of stress. And I use that word stress in like lowercase s so that people understand I don't mean a psychological stress. It's just adding a biochemical stress to the body that it's more things to process. And to a point, it's super helpful. And then if we go beyond that, that's when it gets a little bit dodgy. So if somebody works with works within those ranges. So we talk about optimal ranges sometimes, which aren't really categorized well. Everybody's got their own little optimal ranges for, let's call it TSH or free T3 or free T4, and they have their preference on T4 hormone or T3 hormone, and that actually works pretty well. But there are breakthrough or recalcitrant symptoms that remain, and so it's not good to completely suppress TSH by giving more outside hormones. And what this tries to explain is that, all right, we probably do need to pay attention to what's going on in the gonadal axis, so sex and stress hormones, and what's going on with the stress hormones. So what's interesting is that a lot of times hypothyroidism pops up around perimenopause time for women. Well, it's because naturally in transition, they're not making as much progesterone first, probably in estradiol. And so that's taking a bit of a backseat as ovarian function changes. And that had been potentially masking some of that thyroid dysfunction and has been kind of propping the person up for a time. So it's not necessarily perimenopausal symptoms. Sometimes those are thyroid symptoms that have just been supported because the gonadal hormones have been masking. It really is the right word, masquerading and supporting those systems. The way you described it is right, but I'm going to a little challenge that, right? You
Please.
kind of talk about like, yeah, there's the stress hormones and there's the thyroid hormones and the sex hormones. And even in the paper and in these conversations, I talk about it in a very similar way. But I want to challenge all of our thinking to maybe not thinking about it as a hierarchy of like stress, thyroid, sex hormones, but instead, thinking of them as a triangle of sorts, meaning that any of those systems can influence any of the other two systems. And well, whenever that happens, whenever we start talking about that in physiology, when multiple systems interact with each other in a repeatable and predictable fashion, there's got to be sort of something in between. And that something in between we uncovered through literature that's already been developed was something called the mitochondrial reserve capacity. And I didn't learn about this in school. I didn't learn about this at a lecture or a webinar or anything. This was something that really became, and it's got a couple of names, which is why, but it's not just mitochondrial function for mitochondrial function's sake. When we usually think about mitochondria, and we'll use ingredients in dietary supplements that make some sense here, we hear about CoQ10 or acetyl-carnitine or glutathione, and acetylcysteine as a precursor to glutathione. These all sort of have pieces, and B vitamins and amino acids. These have pieces in the machinery of mitochondria. So they're the nuts and bolts. But there's mitochondria basal function. So this is where we operate all the time and make our ATP for those cells in particular at a base level. And then we have this little like extra. And that little extra, that space is the mitochondrial reserve capacity. And this is where it gets very cool, because there are different signals in the body that stimulate what we call, and another new word probably for some people, is mitohormesis. And that stimulus of either a dietary or an endogenous signal stimulates that mitochondria to go from base to maximum level. And if you have a big maximum level, increased mitochondrial reserve capacity, you're generally doing really well. If you have a minimal mitochondrial reserve capacity, we struggle. And I know your question, I know the people listening question is, well, I should measure that. Not quite a commercially available measurement for that yet, because it's a super dynamic process, right? You can have highs, you can have lows, and depending on what mitohormetic structures are going on in your system at the time, it's in flux. My hope is that we have something available for us, but right now we do not. But that's the language, that's the currency between these endocrine axes that help them and allow them to influence. So I said I was going to challenge something, and it's like, well, are you going to do that or not? My challenge is this. These are parallel axes, parallel endocrine pathways that, because if it were hierarchical, then all we'd have to do is fix stress. If we just fix the HPA axis, if we just give people enough, adaptogens, the ashwagandha and rhodiola and holy basil, if we just gave them enough of that, then everything else would fall into place. And we actually know that's not the case. So that's why I like to dispel the rumor or the potential thought process that these are hierarchical.
I love that. And that's really true. Like, just thinking of the thought framework, right? We're coming from, if we think of traditional medicine, right, we're coming from very linear thinking, very separate, organ processing thinking. And then we come into the CNS world, and then we come into like how you broke down the body. Our system is not AI, right? It's not if and then, right? It is a multifactual living organism with every piece communicating and then making adjustments based on what the other organs or cells need in that moment to keep the homeostasis. And I love that. And that's huge. It's one of the reasons like I geek out over our field and our position in this field, because we get to make those transitions. And that is so cool. Like, cool. I don't know any other word. It's life changing, but it's really brings a deeper understanding of our bodies and how to work with our bodies.
Yeah.
When I was reading this, like, that part stood out so much. And when I think of the client and, like, correct me or challenge me if I was thinking about the wrong client, but, it's some of those clients that all they did was go for a walk, right? All they did was maybe take the dog out for 10 minutes and like, I have to go lay down. Like, I have no reserve, right? And so, or like when you go on, I don't want to say a vacation because that's nice, but like you go on a work travel for a week, and then every time you get back from that, like, I'm wiped out for a week. Like, I have no more reserves left, and we have to rest and we have to build that back up. Is this along the right picture for those listening of when we're talking about this resiliency? And is this the part in your title that we're talking, like, this is the resiliency now that we're coming into for the body?
Yeah, you touch on a really good point, and it's a deep rabbit hole. So we'll try not to go too far into it,
Okay.
but we'll go a little bit into it. Is just that word resilience, right? When we think of resilience, most of the time, especially in this day and age, it's gotten a lot of good press or positive attention, if you will. Resilience and grit, or like stick-to-itiveness. Oftentimes we think of resilience as just, I need to work harder, I need to put my head down, I need to just get through it. And psychologically, there's some really good validity to that. Angela Duckworth wrote a book about it and has done TED Talks on it. And I recommend you watch and read that material, because that's really critical. There's not a good ICD-9 or ICD-10, excuse me, ICD-10 code for poor resilience. And so it's non-diagnostic, it's non-medical, it's just sort of more in the mental health space. But that's not exactly true. You just described really good scenarios where it's just like, this is just physically draining, right? I have exertion-induced malaise, which does have an ICD-10 code. But does that put us in the chronic fatigue kind of category? Or do I have glimpses of good energy during that time? If somebody has chronic fatigue syndrome, they typically don't have any good spikes of positive energy where they can get things done or do what they want to do. Whereas this exertional experience really does lean on, all right, there's a physiologic resilience. What is that physiologic resilience? And again, ATP is actually not the right answer. Ultimately, it is, but what directs ATP is probably more important. You had a really good point. You were talking about like your practice and seeing people that have been on bioidentical hormones and or thyroid and thyroid hormone replacement. And CNSs are in this unique place. If somebody thought they had thyroid problems and they go to their healthcare practitioner and we're told, yep, you have a thyroid problem and here's a thyroid medication, and they feel good and all their symptoms went away. CNSs, we typically aren't seeing them for those problems, right? So our data stream is very, very different. We're seeing the people that the conventional standard of care didn't fully help. It's not that it didn't help and it's not that it hurt. It's just that it didn't resolve or help the person get to all the goals that they needed. So a different lens is required.
Yeah. And that's where we come in too, is like, okay, the basics, nutrients, the substrates, the machine can only go as much gas as it has, right? As soon as we leave out one substrate or one nutrient or one hormone, then the whole machine is going to be impacted. And so while they're looking at the one part of the machine, the sensor or the engine,
Yep.
we're looking at the whole machine in general. So we're talking about this system, and you break down. So I recommend, so the article will be in the show notes. So please download it, look at it, and go through it.
Actually, let me help
Yeah.
if I
Yeah.
can, because there's a point that I want clinicians to understand, and it is in the paper, but I'm going to break it down
Please.
for us here. Is that we talk about phenotypes, and there's phenotypes of plants, right? Like I talk about phenotypes of maca, and there's all these different colors. That's the physical expression of what the genes and the epigenetic expressions look like. Okay. Well, we use that terminology also in and how people present to us as clinicians. And so we use the phenotype language to describe a mobilization dominant energetic state. So that's the person that may have hyperactive HPA axis. They're running on stress fumes, if you will. And then there's another phenotype that is more of like, a conservation dominant allocation where they're downregulated. And if you squint and hallucinate and read the paper, you'll start to see that these are protective mechanisms, right? So if you just look at thyroid hormones because somebody said they had a thyroid problem or think they have a thyroid problem, and you do find out that there is some abnormalities, some sluggish thyroid, well, that might be there for a reason.
Mm-hmm.
That might be there because the HPA axis is hyperactive and it's trying to downshift, if you will. You might have the problem of, all right, hormones are not in good balance. And I have a case because I think talking in theory is fine, but, and this isn't a full thought out case, but I wanted to share it with you. I actually, relatively recent patient was a 41-year-old male. And he came to me and he's like, I'm pretty sure I have a testosterone deficiency. Like I'm tired all the time. Like I can't get going in the morning. Kind of once I get going, I'm doing okay. And, 41 and I've done some damage to my body. Like it kind of makes sense. And all my buddies are getting their testosterone checked. Well, we checked And not only did I look at testosterone and free testosterone and all the relative analytes associated with what I might think was going on there, DHEA, etc. I also found that I ran a panel on thyroid, and his thyroid looked normal. Actually, it looked on the kind of the hyper side of things. His TSH was suppressed. His T3 was elevated a little bit, not elevated above reference range, but elevated beyond my optimal. And same with T4. So he had a functional hyper or hyperactive thyroid. And so I asked the question, why is that thyroid doing that? And it got his labs back, and his testosterone was clean as a whistle, right where I want it to be, not too low, not too high, that sort of thing. But when we started diving into analytes of stress response, certainly we did find some abnormalities there. In fact, DHEA, which was part of that, was just a little bit on the lower side of things, which is always a signal to me that says, hey, that's an adrenal cortex product. So maybe it's spilling, overusing more than it should. Okay. Found out that he was having some just low output of HPA axis. And so because the adrenal hormones or the stress hormones were not doing their substrate switching, telling the body, all right, fat, protein, carbohydrates, which one should I burn and when? The thyroid was taking over. And if I were just looking at that from a completely conventional medicine standpoint, if I were to treat him, I'd have to send him to endocrinology to get treated for hyperthyroidism. And that would have totally tanked him out. I did, I'll say, give him some benefit of saying, and made him feel better about, no, your thyroid is doing fine. The hypothalamus is telling the pituitary is releasing luteinizing hormone, and your testes are making testosterone. So good, we're on the up and up on that. Could I have given him testosterone and would he have felt better for a bit? Yeah. And then he would have crashed. And so we went all the way back and said, actually, yeah, this is the stress response. And we were able to do some really neat interventions there to get him in a place where, yep, that was the key issue. But we got in through a suspicion of sex hormone imbalance. So
Thank you. Thank you for bringing that all full circle, because they do exactly as you said. They talk with each other, and they're going to compensate for each other, and they're going to give to each other like beautiful neighbors. And so you have to look at the whole system to kind of see what is it. And then when we talk about stress, I know you touched on it in the beginning, but I do want to anchor that a little bit more. I started calling stress a toxic load. And the body doesn't know a difference, right? Is it mental stress? Is it physical stress? Is it just that I don't have enough nutrients? Is it that we're doing a workout fasted and our body's like, I have no capacity for this right now, like causing a stress. So for your case study, for your client, was it a physiological stress? Was it a psychological stress? What was it for him, if you don't mind, that really shifted that stress piece? Because we're going to talk about stress, and most people, as you know, they're going to think mental stress when that's only a tiny piece of the stress of the body.
Yeah. Absolutely. And now we're cooking with gas, because now I'm like all jazzed up, because you're talking about the allostatic load, right?
Yeah.
That stress load is allostasis. It's the amount of physical, chemical, emotional stressors that one perceives. And so I'll talk about the case, but I want to just bounce back with the theory a little bit. Is that is that's Bruce McEwen has done a ton of work on that. He's sort of the giant when it comes to allostasis or allostatic load, and that theory holds a lot of water. It's very well reproduced. It's very well understood, and for the case that I just mentioned, it was a little bit of both. And so this is where it gets super interesting, because he had lost probably 40 to 50 pounds, changed his diet significantly. He was working out really well. He runs his own business. He's a tattoo artist. And so there's some mental, physical stressors that go along with both of those. And what was really cool about it is that It's both. It was for him. It was both. The whole allostatic load was taking place, and he didn't realize it. And most of the time we think, all right, you lost weight, you're in now a normal weight range. That should be good. That should be healthier, but it's actually a stressor. Oddly enough, we usually see thyroid downregulate, right? We see metabolism slow when somebody loses weight because it doesn't have to carry as much cellular machinery around. In this case, that wasn't happening. He was going the other direction with it. So to lose all that weight, to put the physical training stressors on, the dietary stressors on, the business owner stressors, we were seeing something very different than what we would usually see. And so that's important to understand because that keeps us from putting people entirely into boxes. But there was a clinical pearl that I wanted to share with you and anybody else that might listen to this. And that is that there's good evidence now that shows that perceived stress is a really good indicator if it's there. If perceived stress is high, we probably have lower adrenal output. Not all the time, but it's pretty well established. But the wrinkle is when perceived stress is low. And when I asked him, hey, do you have a lot of stress in your life? What was his answer? His answer was no. But the biochemistry was very different than what he perceived. And so when perceived stress is low, don't believe it. Not that you shouldn't believe your patients and not believe you shouldn't believe your clients, but the reality is that low perceived stress doesn't correlate well with stress response biochemically. So in his case, it just did not.
1,000%. Have you heard of the device Whoop?
Yeah.
Yeah. Would this fit into a tracking measure? We said in the beginning, like there's really nothing we can do to measure this. But I have used Whoop with some clients and have found that it's been beneficial because, again, mentally, they're cool, right? Like, I have this a little stress, or I wouldn't be seeing you, right? I got some health stressors I need help with, but in the main thing, and most of the time, if they're to a point that we need to monitor this, right? They can't go for a walk or they're being really limited. We got to find out what it is. For anyone who doesn't know what Whoop is, it's a wearable device that kind of tells you, I'm going to call it the toxic load, like where your stress state is. And I have seen people wake up with maybe it wasn't the Whoop, but like an Aura ring or something, just freaking out, like, your stress is insane. Like, what's going on? They just had to poop. Like, I just wanted to like kind of bring that full circle of all the little tiny things that can actually add up to that stress response that mentally we're going to look at that and be like, I'm cool. But the body's like, wait a second, we can't detox. We're not allocating resources. I can't communicate or whatever it is.
Yeah. And so far, right, when you don't have a good marker for mitochondrial reserve capacity or that spare respiratory capacity, as it's also known as, when you don't have that, you got to find an intermediate marker, right? And we can't be drawing people's blood for cortisol, even though it's not a great marker, but we can't be doing salivary cortisol tests or urinary cortisol tests every minute of every day. And so one of those intermediate markers that I'm paying attention to is heart rate variability. And so Aura Ring does a good job of that for sure, especially overnight. It also has like a stress response readout. All the wearables have their version of it. Apple Watch, name your brand. That's probably our best bet. Also, we can get a lot of data from continuous glucose monitoring, right? As stress goes up, blood glucose follows stress, and that makes sense from a survival standpoint. And so if we see glycemic excursions that run high, we can pretty much guess that was due to a stress response or dietary response, right? Was it the banana that you had, or was it the fact that you had to wait in line too long at the bank? I don't know. One or the other. But if you didn't have that banana, or you had a low glycemic load type of meal and your blood sugar is rising, that either means machinery is broken and we need to repair that cellular machinery, or maybe it is an HPA axis activation. So a couple of different ways to look at that for sure on an ongoing daily basis. And the wearables are for sure the least invasive.
Awesome. Thank you for that. We talked about, or you had mentioned, if this was linear, all we got to do is treat the stress or give the adaptogens, and everything downstream is going to kind of fall in line. And just to prove your point that it's not like that, sometimes, because again, physicians see first, so we pick up the damage afterwards sometimes. They're really quick, like, oh, here's an adrenal rescue, or here is something with maybe even some glandulars or something, if they think. But if you think about it too, if your adrenals are turned on and you are in that stress state, if you give it more fuel, we can actually tip that toxic load or that stress state even higher, because we're not supporting the axis of the communication, right? Most of the time I'm switching to more of a HPA axis support, and that can actually give the client a lot more stability and energy. I know adaptogens are so hot on the market right now, and overall they're pretty good and they're pretty safe. But once you can kind of get more into the framework that you're talking about and you understand the communication and the axes, you find like that's your power. Even like the T1, the T2 modulators that you were talking about, finding their crux of what balances those are powerful, not just saying, hey, we're going to shut that off.
And I think if somebody hears us talking, their eyes might glaze over and say, okay, well, this got really complicated really fast. And if they are thinking that, if you're thinking that, that's good. Because that's what frameworks are for. They're supposed to encapsulate kind of almost all different versions of things. And there isn't like a this then that kind of response when you're thinking about holistic medicine in general, but especially in these endocrine axes, right? You may have to treat or support multiple systems at a time at a lower dose, a lower rate. You don't have to throw, boom, T4 thyroid hormone at it, but maybe somebody needs the iodine and selenium to help produce those hormones and to support the deiodinase enzymatic activity. I was chatting with Maria Scudo, who's a mitochondrial bioenergeticist.
Ooh-wee.
Yeah. She's out of Italy, and she's the editor actually for International Journal of Molecular Sciences in our area that we're interested in. And she talked about how mitohormesis in particular has a very dose responsive curve. If you don't stimulate the system enough, the body maladapts. If you overstimulate the mitochondria, the system maladapts. So you have to get it right. So that puts pressure on us, the clinician, as well as the person trying to get better. But also with natural substances, ingredients, foods, supplements, there's a lot more wiggle room than there is for using medications for mitohormesis. So that's where I feel really good about, all right, we can play around with this. We can experiment as long as we're measuring the output that we're looking for. And when I say measure the output, I don't mean always labs. I oftentimes mean let's pay really close attention to the things that maybe it's not your primary concern, but it's a indirect measure or an indirect marker towards it. I use an example like this. I had a young lady come to see me, and she had secondary amenorrhea. So she had her period, and then it stopped. So we would go through the process and like, okay, is this like an athlete's triad? Is she over exercising, under eating, not getting those substrates that you talk about? And I was like, oh, this could be it. The reality is that that wasn't necessarily the case. But the big outcome is to get her period back, right? So we can't just pay attention to that for a month. We can't pay attention necessarily for it for 2 months, because that only happens once. There's not enough frequency of symptoms for us to pay attention. So I asked her, and her mother, who was working with her too, said, look, that's not gonna be the only goal. What I want to do when we're doing these mitohormetic and endocrine axes balance I want you to pay attention to mood changes, your sleep, your energy throughout the day, and any kind of pain or discomfort that you're having. And so, and I don't mean uterine discomfort, but I'm looking at things like musculoskeletal stuff, potentially headaches, those sorts of things. And I want you to measure this 3 times a day. Sleep usually only measure once or twice, right? Did I fall asleep? Did I wake up groggy and feel well rested? Which one was it? But energy, mood, and pain or discomfort can be measured pretty frequently. I said, if we're making progress over the course of 3 weeks in any one of those parameters on severity or duration or frequency of any of those symptoms, we are directionally going the right way. And so sometimes I ask clinicians to step back a little bit and say, yep, somebody has a chief complaint or a primary goal. What are the smaller goals? What are the atomic type of goals that we can make progress on to see if what we're doing is helping or if we need to change directions?
Beautiful. And correct me if I'm wrong, but really what you're doing in that moment is building the resilience of the cell, building
Yep.
the resiliency of that axis as the foundation. Yeah. And we get to see that. And if there's any non-clinicians out there and you've ever been kind of annoyed that they make you do a 3 to 10 day journal where you're measuring everything,
Yeah.
I swear there's a method to the madness. We're looking for patterns and it's going to be worth it because not everything you can get from a blood draw or from a spit test or some urine. You really just have to look at the processing and how the body is working. What exactly is the body telling us mentally, physically, spiritually, emotionally? Because that's actually going to tell us the pulse of where that organism is at in that moment.
And journaling shouldn't be underestimated. I mean, yep, sometimes it's a pain in the butt and annoying to pay attention to all the things. That's why I kind of like limited it to 4 things. But if you can kind of really explain your experience moving through the galaxy here, that's great. In research, and sorry, nerd comes back, is that sometimes we do these big scale research studies, right? These maybe prospective studies where we just kind of monitor everything and we p-hack. We're looking for the statistically significant correlations because we don't actually know what's happening. And we're going to see more and more of that as AI gets involved in data sets on and health contributors. But we've been doing that for a long time. It's not necessarily the best thing to do. You should have a theory about what you think is going to change, but sometimes you don't know. And so you look at it all and then look at the relationships between things. And sometimes the clinician has to just squint and hallucinate and read through 10 pages of a journal and say, wait, I'm seeing a pattern that wasn't obvious to me before. And now let's test that pattern and see if it makes sense with your experience. And if we can support it, great. Here's one theory on how to support it. And then are we seeing those relationships between the symptoms change? And I use symptoms. It might not be symptoms. It might just be experiences. So
Wonderful. Thank you. Are there any parts of the article that we did not touch on that you feel is really important to kind of bring home and bring to our attention?
yeah, I mean, this is more of a bottom line. I don't think we really missed big parts of it. The reality is that I like to kind of make it simple to understand is that, hey, when resources are tight, physiology becomes economics. And that's why you read in the paper about things like, well, allocation, that's sort of a monetary word in and of itself, like, but budget and resources, we talk about it in terms of currency, um, not just to better understand it, but it is a really good model for understanding that there are gives and takes. There are sacrifices and opportunities at every turn of physiology. And the other thing that I like people to remember is that the body doesn't really run out of hormones first, it runs out of energy. And by hormones, I mean sex hormones, I mean thyroid hormones, I mean stress hormones. We don't run out of hormones first. And then last but not least, because a lot of people that have lower physiologic resilience come to us with the symptoms that we've kind of been talking about or had mentioned is we often do think thyroid, and we're not necessarily wrong. But I want us to remember that the thyroid isn't just a thermostat. It really is a throttle. And our body up throttles and down throttles as needed. And it's doing that for a purpose. And I do think in almost every case of these like physiologic resilience, the thyroid needs something, but it might not be thyroid hormone from outside the body. So those are sort of my bottom line takeaways that I think are important. But you covered it really, really well. We didn't get talking about the inflammatory issues. We didn't get talking about the circadian issues. We didn't get to talking about all those other things, but those are in the paper too. So feel free to look at those sorts of things. Methylation is included in there. We tried to make it as rich and robust as possible so that it was relevant to the broadest group of people possible.
And it really does touch bases. But once you understand the systems, right? And you've experienced them. We've all experienced them at some point, right? We get high stress, we can't sleep that night. Ooh, or we have a pit in our stomach and we cannot eat, or whatever those inflammatory responses, right? For stress, and we have uptake of glucose that happens too long. Well, now we have that low grade inflammation, right? All those clinical pieces, they start to click together. And when you read the paper, you're going to have the aha moments because it is very well written to really tie it all together. But absolutely. So anchoring it back into your finances piece of it, because that was true. And that's what I have a whole banker analogy I use. I'm not going to do it here. I'll do it on a blog later. It's like 15 minutes. But it breaks down the whole systems and how and why we feel the way we feel sometimes. And that your day starts when you wake up, right? When that cortisol kind of increases, that still happens. So yesterday has been detox for a brand new day. And every day gets to be a brand new day. So you do have a playing field. I guess I want to say you have a playing field that you can, if you are journaling, you have a day-to-day report card to see how the body is going. And there are so many different markers, and everyone's marker might be different. We talk about the thyroid patient, right? I'm tired. I'm just too tired. My hair's thinning. My nails are thinning. Like, bowels are slowing down. Like, what's going on? I'm irritated. Like, help, help. But it may come to us and they just may be, I'm anxious and now I have anxiety and now I can't sleep. And we can be
Right.
looking through this same framework to really get a deeper understanding for our client. The last question I want to ask is what do you think would be the most practical way for maybe a new CNS or a new physician or someone saying, okay, I really, I'm digging what they're saying. Like there's a lot more to this. And this actually gives me a framework to work off of. Can you explain a little bit of exactly what that framework looks like and how they would use it transferring this into their practice or this data?
Yeah. Well, it's not as simple as run all these tests and then treat the labs. Because we hear about people saying, test, don't guess. I agree with that to a degree, but it's not really the case. So it's not just here are the labs and fix what you find. That would be great. It's also not just listen to symptoms and see what kind of, patient presentation you have and then treat those symptoms. Both sort of miss the mark. A little bit more open-ended evaluation of thyroid hormones is useful. The broader version of looking at stress response, choosing whichever version you're going to do of that would be useful. And then understanding that the labs can frankly lie to you a little bit.
Yeah.
And it's an important thing to pay attention to of micronutrients are key mitohormetic structures. So we think about vitamin D, we think about iodine, we think about selenium, some of these baseline type of micronutrients, which you may be getting or may not be getting from a multivitamin and a good balanced diet. And so paying attention to micronutrients first is probably a relevant strategy. And the other thing that we probably see is, look, if you overshoot, you give what you think is right according to the standard of care and the person doesn't feel good, you didn't win. You don't win by balancing someone's labs, you win by making someone feel better. And so that framework says pause and reevaluate other systems that are coordinated with the one that you're paying attention to most.
1,000%. Thank you so much. I'm going to say it. We'll see if we edit it out because I know we just kind of closed, but it came into my head and I just really wanted to kind of anchor it. There's been a lot more discussion on my podcast about children than I was expecting, which I think is wonderful too. You mentioned about the hormone changes in hypothyroid. And I've also noticed like ladies before starting their menses, there's huge shifts in the thyroid and just kind of showing that relationship again in a different phase of life. But then also in your paper, you also mentioned like these prolonged stressors and different parts really go into the epigenetics of the framework for, really the rest of our lives on how these operating systems are going to find their baseline, on how they're going to communicate, on what they're going to tolerate, how long they're going to tolerate that. And when we talk about selenium and iodine and zinc, magnesium, I listed the minerals, but when we're talking about our needs, we have to really look at that and think of it into childhood, right? And really making sure that all of these substrates are being there to build the foundation, because we can't ignore that. Like when we have that menopausal person coming in, we have to know also like their body has been designed to specific set points and different allocations and different mechanisms of protection that are going to be different than the next client. But we also have to take that into consideration when we're looking through these phenotypes. When we're looking through the phenotypes of the person and saying, how far can I actually get them? Because we may not be able to go from, okay, she's having panic attacks or anxiety down to nothing, right? And so that's are we moving it? But where did they come from? Because that is going to impact what you're looking at when they're older.
Yeah, absolutely. And we touch on it, but very briefly on, early life adverse events. So things like trauma, and they have an impact. And when those are present, it suggests to us that, that mitohormetic range can change. We also know that, and if you just time it right, and people have seen this in practice, or you will eventually, if you haven't already, is that you get a child during a growth spurt or right after a growth spurt, and suddenly their TSH looks like they're hypothyroid, but they're tall and they're slender and they have good energy, but for some reason it looks like they're hypo or sluggish thyroid. That energy allocation system is at work, at play, and it's doing its job. And so sometimes it's just a time scale. It's just waiting on it, being a little bit more patient, giving the body some grace. It doesn't mean to not do anything. It just means don't be overly aggressive on some of the treatments that you might choose.
Yeah, and really coming into just trusting the body a little bit more. Like the body's on your team. Even if it doesn't feel like it, it is your best friend on your team, keeping you alive, rooting for you, no matter what. So like when we start looking at the body through that lens too, a lot of times, speaking for myself, look at out from the physician, be like, I don't know if I can spend all this money or if I want to do hormones right away. I'm here at a functional thing trying to do something natural. And I get the gratification of saying, great, good job, body. This is telling us where your body's at. And we're going to do X, Y, and Z. And if we